Hello, good evening, everyone. It's just after 8 o'clock now, so we should be ready to start. Thank you all for coming tonight for the next of the ventilator rounds. Tonight, Dr. Carola will be talking about double triggering. So it should be a great session, and we're all interested to hear what you have to say. Just a little reminder about ICU Reach. On our website, there's the option of becoming a silver member. And with that membership, you'll be able to access over 50 different videos that have been pre-recorded so that you can get more content out of that. And we'd be really grateful if you could sign up. So just going to pass on now to Dr. Carola to start the session. Thank you.
Thank you, Grace. Bismillah ar-Rahman ar-Rahim. Assalamu alaikum, Jamia. Do you see my screen?
I can see your screen, and it is the start of the video on the live Facebook.
Excellent. So today is going to be interesting, and we'll go in details about to discuss double triggering or mechanical ventilation, an event that happens a lot, and we will learn how we can identify it and then see what we can change on the ventilator in order to eliminate double triggering. First, I want to remind everyone that when you put someone on the ventilator, you're dealing with a dual pump system, meaning that you have the patient who's still breathing, of course, if you do not paralyze the patient, and you have the ventilator. So on one side, you have the ventilator with the positive pressure. On the other side, you have the patient with a negative pressure. And always put in mind the equation of motion that dictates how the air is going to flow into the chest. And that equation is actually the change in the pressure that should be equal to the resistance multiplied by the flow plus the change in the volume divided by the compliance. And you need to remember that the change in the pressure is actually the combination of the pressure generated by the respiratory muscles plus the pressure generated by the machine. Of course, change of the pressure meaning the combination of this, the muscular pressure plus the ventilator pressure minus whatever is in the system, which is at end expiration, which is the PEEP. So with this, you need to look at the ventilator pressure and the patient pressure. And this is actually where we have the synchronization or the dyssynchrony between what the patient is doing and what the machine is doing for the patient. And in order to understand asynchrony or dyssynchrony, whatever you want to call it, you need to understand the dynamics that occur when we deliver a breath, in case the patient's still breathing. And I'm going to explain that in details here. I'm going to concentrate on the trigger here because this is actually what we're going to be discussing today in terms of double triggering. And of course, you know that there's a certain threshold that we call trigger threshold that the patient needs to achieve in order to trigger the ventilator. And when the patient starts inhaling, the intrathoracic pressure goes down. And it will get to a point where it will reach that trigger level. So that drop in the pressure from the PEEP level here to this level here, we call it trigger pressure. This is the pressure that triggered the ventilator. Now, at the same time, that took some time. So when the patient starts inhaling, he needs to drop that pressure to this certain level, and the time that is elapsed from the beginning of the inhalation till we reach that trigger level is called the inspiratory trigger time. And it's actually here depicted as the DT, inspiratory trigger time. Now, once the ventilator is triggered, of course, that pressure goes up to slowly, depending on the rise time, and it will take time before that pressure reaches the peak level again. This is what we call time to return airway pressure to baseline. And the delay from the initiation of the patient's inspiration till the time we reach the peak level again, we call it the inspiratory delay time. So this is what happens.
Sorry, Dr. Carol, I think your volume's gone off. If you can unmute.
You hear me now?
Yeah, thank you.
Okay. So again, once the patient starts breathing, the pressure goes down, and once we reach that trigger level, the ventilator is triggered, and the pressure goes up to whatever pressure level, if it is pressure control mode of ventilation, or to the pressure that is required to deliver the volume in volume controlled mode of ventilation. Now you can see here, this is what you see on the ventilator. You see that initial drop in the pressure. But after that, you see the positive pressure here. What you don't see on the ventilator is the negative pressure of the patient. You can see here how the patient continues to drop the inspiratory pressure. This is the intrathoracic pressure. And without having esophageal probe, you cannot measure the intrathoracic pressure. So this is something that you don't see unless you have an esophageal monitor and the probe is connected to a pressure diaphragm, and then you transmit that pressure to the monitor. Now notice that the breath is actually ended here. You can see that the patient stopped his inspiratory efforts, and the inspiration ended at this point here. However, notice that the ventilator did not end inspiration yet. And the inspiration ventilator is ended here. And that's what you notice here, that the patient started to exhale. So the patient is exhaling and the ventilator is still in inspiration. This actually is called the expiratory time delay. So this is a time delay from the inspiration end of the patient. And this is actually caused by your settings. You set the inspiratory time longer than what is the patient's inspiratory time is. Okay, and that's why you see here the start of the expiratory effort of the patient, and you can see that the pressure rise above the plateau level in this mode of ventilation here. Okay, so let's put this in mind and try to understand double triggering based on this mechanism. Excuse me. So what you have here is a normal flow over time. You can see it's a square wave. So this is volume control mode of ventilation. In expiration, you can see it goes to the peak expiratory flow before it decelerates back to the baseline. This is the inspiratory time, and this is the expiratory time. This is the inspiratory time of the ventilator. Okay, so at the bottom here, what I see is the esophageal pressure, and that means what the patient is doing. As you see, the patient is inhaling earlier than what the ventilator inspiratory time is. So the initiation of the inspiration is actually at this point here. However, the patient needs to drop that pressure to the trigger threshold before he's able to trigger the ventilator. And you can see that the ventilator is triggered at this point. And the machine delivered the breath, and this is a square wave flow is delivered by the machine. You can see that the inspiratory time of the patient is tracked here, the pressure continues to go down. This is esophageal pressure. This is because of the inspiratory efforts of the patient. And you can see that the inspiratory time continues for this duration here and ends at this point here. This is the end of inspiratory efforts of the patient. So we're done with inspiration. The patient is done with inspiration. However, in this example here, the inspiratory time on the ventilator is not done yet. So this is in normal condition. This is perfect actually, because that's what you want. You want the patient to exhale. You want the patient to finish inhalation prior to the ventilator inspiratory time. So, and you can see that the pressure goes up to a positive side of the pressure curve, and you can see the expiration nicely with the expiratory flow decelerating back to the zero line. Now, let's take a look on this example here and see the difference. So this is what we just talked about. This is the normal flow over time curve for a patient with a set inspiratory time on the ventilator. Now, if this patient inspiratory efforts lasted longer than the ventilator's inspiratory time, what you will see here is that this is the start of inspiration at this point here. This is the point of trigger, and this is the negative inspiratory effort of the patient. Notice here that the ventilator inspiratory time is finished. However, the patient did not finish his inspiration. And you can see that he's still having a negative inspiratory time here. However, this is the trigger threshold. At this point here, you see that the pressure is actually above the trigger threshold. It is an inspiratory effort of the patient, however, is not actually big enough to trigger the ventilator again. It caused some changes in the expiratory flow. It amputated the expiratory flow. You can see this is inspiration, this is expiration. That's why you see a drop in the expiratory flow of the patient on the ventilator. This is because of continued inspiratory effort of the patient. However, it is not at the level that it can trigger the ventilator again. So let's see the next example here. So what you see here is a patient who has the first breath, square wave, and this is the pressure that is generated by the machine to deliver the breath. And you can see the first tidal volume here. So this is a normal triggered breath on the ventilator that is delivered as a volume control breath. What happened here is there's another breath, and this is the inspiratory flow here. Notice that you don't see any expiratory flow. And you will see another breath after that, exactly similar to the first one. And this is flow over time. Now this is volume control mode of ventilation. We deliver the volume, and this is the pressure required to deliver the volume. The patient did not end his inspiration. He was still inhaling here, and he reached a level that he can trigger another breath before the start of expiration. So that second breath is triggered by the patient. And you can see, since it is volume controlled, it's going to be delivered with the same amount of flow. The flow goes up to the set level, and it will deliver the same tidal volume. You can see the tidal volume is stacked on the first one. So this is the first tidal volume. You see plateau here, this is a plateau, and then you see another tidal volume. Since this is volume control mode of ventilation, the machine will utilize whatever pressure is required to deliver the volume. And since we have volume already in the lung, you need the plateau pressure to keep that volume in. On top of that, you need another pressure to deliver the new volume in. And that's why almost the pressure doubled here. You have some plateau here before exhalation. So this is the ventilator inspiratory time from this point to this point. However, the patient's inspiratory time is longer. You can see that it is actually lasted longer than the ventilator inspiratory time. And based on that, the patient reached the trigger threshold to trigger another breath. And that another breath is delivered exactly similar to the first one. However, it requires higher pressure. Now, in this example here, you will see a normal breath here. It's a volume controlled breath, normal expiration, back to the zero line. This is a trigger threshold. You can see the drop in the pressure in initial breath here. And then that breath is delivered with a fixed flow and generated a fixed tidal volume that is set by the operator. The patient did not finish inhalation. However, the ventilator inspiration time is ended. Supposed to be going in expiration, but the patient continued to drop the pressure, and you can see the pressure drop with the second breath. So the patient was able to trigger the ventilator again. Another breath is delivered with fixed flow and fixed tidal volume. You will see here that the continued efforts of the patient caused the airway pressure to drop below the trigger threshold and trigger another breath. The indication that the patient is breathing here is this scooping of the initial pressure here. And the inspiratory time is actually imaginary here. It is from this point to this point here. And the second breath is stacked above the first one. The reason why you don't see it stacked here in some ventilators, as we talked about in the air leak session last week or the week before, the ventilator will recalibrate. This is a recalibration to zero line. That's why it's vertical. And this volume is actually added to this volume. So what you see inside the lungs would be 300 plus 300, that's close, total of 600. And then you, of course, require higher pressure. So notice that the patient is not breathing anymore here. So he's not participating in the negative pressure anymore. The breath is already triggered. So the machine is going to utilize a pressure to keep the first air in, which is a plateau pressure, plus we need the pressure to deliver the second breath, and that's why the pressure is almost doubled. And the volume is doubled. You can see the second breath here. Of course, this is actually patient's effort. So he tried to exhale actually at this point. Next, you see that we have now a large tidal volume inside the chest. It will generate high peak expiratory flow. And you can see the area under the curve and the flow over time curve that is actually representing exhalation of both the initial breath tidal volume and the second breath tidal volume. Now, another example here. This one I explained without looking at the esophageal pressure. This is the first breath and the second breath. So let's take a look on this example here. However, we're looking now at the esophageal pressure. So you don't see the volume, you see only the flow, the pressure, and the esophageal pressure. So first, this is our trigger threshold. And you will see that the first breath is triggered at this point here. This correlates with, let me just get the, why don't we start from the first one here? So you can see this is the esophageal pressure, and this is the trigger threshold that is actually depicted on the esophageal pressure tracing. And the patient had to drop the pressure to this point here before he was able to trigger a volume controlled breath. You can see the pressure goes up gradually, the flow goes up to square wave flow waveform, and the pressure is continued to drop. After that, the patient stops in his inhalation, and inspiratory time is elapsed by the ventilator. That's why the flow goes down to 0, and the patient goes into exhalation. Now at this point here, in the next one, it's similar to the first one. The patient started to breathe. He initiated a negative pressure. You can see how we reach the trigger threshold here, and on the pressure over time scalar that generated or triggered the ventilator to generate a breath. And that breath is a volume controlled breath, square wave flow waveform. Now take a look on the pressure, on the esophageal pressure. You will see that the patient continues to drop that pressure in a negative territory. And in fact, when inspiration ended, and this is the point of end of inspiration, probably early a little bit, the column needs to be moved to the left a little bit. When the ventilator finished inspiration, the patient did not finish inspiration yet. Okay? And you can see that the pressure was still negative. And in fact, it is below the trigger threshold. Okay? That, of course, triggered the ventilator again. And you can see here that pressure is below the trigger threshold, and that triggered the ventilator. The pressure goes up almost double. This is the second tidal volume. This is the flow of the second breath, and the area under the curve is the tidal volume. So the continuation of the inspiration by the patient results into triggering the ventilator again, because the pressure is under the trigger threshold. Now the ventilator would deliver the same tidal volume. The inspiratory time will be the same also. So it is this is a volume control mode of ventilation. So you set the tidal volume and you set the inspiratory time. The second breath is going to be exactly the same, except that we need to use higher pressure, since this is a volume control mode of ventilation. And at the same time, the expiration is prolonged. Now there is, if you go back to physiology, there's something called Herring-Brouwer reflex. Once you have a large tidal volume inside the chest, it will actually stimulate that reflex to deliver or to cause a prolonged expiration. And this is actually needed to empty the lungs. If the second breath came back here, you would have triple trigger actually for the ventilator, and you don't want that. This means that you're going to be having dynamic hyperinflation syndrome. So this way, with this reflex in place, will inhibit any further negative inspiratory efforts by the patient, and will allow for a prolonged expiratory time where we can exhale everything that was in the chest as a result of these two breaths that were triggered twice. Now, how is it different in pressure controlled ventilation? The first one was volume control mode of ventilation. So how would you see double triggering in pressure controlled mode of ventilation? So in pressure, the first one is flow, the second one is pressure, and the third one is volume. And the difference between volume control and pressure control: in volume control, you fix the volume and the machine will deliver that volume no matter how much pressure is going to be taken. In pressure control mode of ventilation, you determine the pressure that you set on the machine, and the volume will be the results of that, of the resistance and the compliance of the respiratory system. So the volume is variable. So you see here, the first breath is given with a fixed pressure. The pressure goes up to level of 15 here. And then for that inspiration time ends here, the pressure is dropped. However, the patient did not finish his inspiration yet, and that pressure is actually dropped below the threshold level again to deliver another breath. Okay. So we'll come back to it. The first breath is delivered with a decelerating flow waveform. You can see the deceleration nicely here. This is typical pressure delivered breath, and resulted into this tidal volume here. You can see two boxes here. So 200 or 400, whatever you want to put on the unit here. Okay. Now the machine is triggered again before exhalation. You don't see any expiratory flow here. And the volume is inside the chest. The machine is triggered again. And the machine will deliver the same set pressure because it's a pressure control. Now that pressure is, you can see, is exactly the same as in the previous one. However, we have volume here, meaning that this pressure now is going to result into in less tidal volume and less flow. You can see that the flow is lower than the first one, and the tidal volume is lower. Again, this is based on equation of motion. Okay. In the equation of motion, you already have tidal volume on the right side. So given the same pressure again, it's going to result into minimal or low tidal volume that is stacked on above the first one. So there's a stacking, but for less tidal volume compared to volume control mode of ventilation. And the inspiratory time of the ventilator is depicted here in the yellow rectangle, and the patient's inspiratory time is longer than the ventilator inspiratory time. Okay, so again, the continued negative inspiratory efforts of the patient beyond the ventilator inspiratory time resulted in triggering the ventilator once more before expiration start. Okay. So this is the same mode of ventilation. This is pressure control mode of ventilation. This is the first breath that is triggered by the patient, and the machine gave the set pressure. Then expiration started. However, the patient was still taking inspiratory efforts. This resulted in triggering the ventilator again. The ventilator gave the same pressure as the previous one. However, since we have tidal volume already inside the chest, it resulted into lower peak inspiratory flow and lower tidal volume. This should have been actually lower than the first one. And the stacked volume will be, the inspiratory volume will be the combination of the inspiratory volume of both breaths together. So the difference is that the pressure in the second breath is exactly similar to the pressure in the first breath. In volume control, the pressure will be higher than the first breath, and the flow is lower, and the volume is stacked on each other. So this is a real example of a patient that started his breath, the first one here, and the pressure goes up to 35, around 35. And then the second breath is started here. You see that the volume is the same, the flow is the same. Of course, this is ABV, CMV, meaning that it's a pressure regulation, and that's why you see the decelerating flow wave. The second one will be given at the same level as the first one here, and resulted into similar tidal volume for the patient. I don't have the volume here, but you can see that there's no expiration, minimal expiration here, but the second breath started right after the first one before complete exhalation. Similarly here, the first one is not started by the patient. So by the way, it doesn't have to be both breaths started by the patient, no. You can see here that the first one, the pink indicator, is for inspiratory efforts by the patient. You can see this is started, it's a time triggered. This is started by the machine, and you don't see inspiratory efforts by the patient. However, the patient started inhalation right after that. Okay, and he continued inhaling despite the fact that the ventilator went into expiration. So this is the inspiratory time of the ventilator. However, the inspiratory time of the patient is longer. And you can see here barely made it into expiration, a little bit of expiratory flow here before the patient initiated another breath and resulted into the tidal volume. This is the same patient also. You can see that this problem is continued for the patient. The inspiratory effort of the patient is prolonged, causing double triggering almost every breath. And the way we deal with this is actually, since the mechanism is prolonged inspiratory time of the patient compared to the ventilator, so the answer is very easy. You would need to prolong the inspiratory time on the ventilator. So if it was set at 1 second, you would go to 1.2 and observe. If that eliminates the double triggering, you solve the problem. If it does not, you go even higher on the inspiratory time. The other thing you can do is you can sedate the patient in a better way. If you think that this is actually causing some asynchrony and you don't want to have stacked volume. Of course, in patients with ARDS, you don't want to have stacked volumes. And if this is happening very frequently, like what you see here, almost every other breath or every breath, that means you're not giving the patient protective lung strategy. So if you cannot eliminate this by prolongation of the inspiratory time on the ventilator, at that time you need to sedate the patient deeper. And sometimes you may have, if this is not eliminated, especially with COVID patients, the inspiratory drive is huge for the patient, and this may not be eliminated unless you paralyze the patient. So make sure you sedate the patient very well. You have a BIS monitor on, and make sure that the BIS monitor is between 40 and 60 before you paralyze your patient. This way you can control the you can eliminate double triggering on the ventilator, and you can make it smoother for the patient, able to synchronize with the ventilator in a better way. Thank you. Grace?
Yeah, thank you very much. Hopefully my video will be working now too. For your informative talk tonight, and just teaching us a bit more about double triggering. I don't know if anyone has any questions tonight, but if you do, firstly, it's good if you want to ask them by putting your hand up. So if you can go ahead and do that. If anyone then has other questions that they would rather not say out loud, you can put them into the chat. So far, there's no questions through yet, but yeah, if you have a question, go ahead.
يعطيك العافية دكتور مازن.
أهلا دكتور معاذ. Go ahead.
Any role of increasing the tidal volume to manage this double triggering? يعني does double triggering mean the patient didn't get the enough volume that he need?
No, it is not related to the tidal volume. Now, except in volume control mode of ventilation, you set the tidal volume for the patient. Let's just say that you mean indirectly, right?
Yes, maybe he tried to get
it's
more
actually
air in.
Yeah, so the cause of the prolonged inspiratory time of the patient could be either because of the increased inspiratory drive, as I mentioned with COVID patient, those patients having a firing of the respiratory center very deeply, frequently, and in prolonged time. So that could be central reason. At the same time, it could be that you're not giving enough to the patient. So the patient, and that's what you call air hunger. So if you're not setting the tidal volume appropriately for the patient may be trying to suck more air into the chest. So now, remember, in volume control mode of ventilation, if the patient is breathing with the ventilator, the pressure on the ventilator will go down in order to get the volume in. However, the patient cannot get more volume than what the ventilator is giving him. So if you set it at 350, for example, and he would need 500, or he's actually looking for 500, he would continue his inspiratory effort to try to get that much tidal volume, and it is not allowing him. Now, the answer to this, if this is the case, it's actually all falls within protective lung strategy. Do you really want to give him larger tidal volume? Or this is the tidal volume that he needs to get based on the protective lung strategy? So if your calculations are wrong and you need to give him higher tidal volume, you would set higher tidal volume for the patient within protective lung strategy. Of course, if the patient is not in ARDS, you can give him 8 ml per kg. If the patient is in ARDS, not more than 6 ml per kg of ideal body weight. But if you say, well, despite that I'm giving him the ideal tidal volume for his body weight, he's still doing this, at that time you need to sedate the patient. If you do not increase the tidal volume, if it's going to go above the protective lung strategy. So that's in volume control. Now, in pressure control mode of ventilation, you set the pressure, okay, and the patient sucks the air in. So in fact, actually, he's free to get whatever air he wants. So if he continues to breathe, he will get that larger tidal volume. So in pressure control, because you're setting the pressure and the patient sucks the air in based on his inspiratory efforts, at that time he may get larger tidal volume. So if there's air hunger, that would be in volume control mode of ventilation, not in pressure control mode of ventilation. I hope it's clear.
Yeah, it's clear. Thank you very much, Doctor.
You're welcome.
Thank you. Does anyone else have any questions they want to ask directly to Dr. Carola? Well, we have a question in the chat for now. So this is from Dr. Faisal. Is it different if I use flow trigger, or is there a difference if I use flow trigger?
No, it is not different, actually. Remember, there's no flow without drop in the pressure. So in fact, when we see the trigger is caused by first drop in the pressure, then increase in the flow. Now you're setting the machine to respond to either the drop in the pressure or the increase in the inspiratory flow. So, and we usually, I mentioned that earlier, actually in other sessions, most of the machines now are set for the flow, to be triggered based on the flow, because the sensor that we have is more responsive to flow changes. So it is the double triggering has nothing to do with whether the breath is triggered by the pressure or by the flow. If the patient is able to generate, let's say if the machine is triggered by the flow, if the patient is able to generate a flow that is high enough to trigger the ventilator again, he will have double triggering. If the patient is not able to generate that required flow, you don't have double triggering. So it is prolonged inspiration and ability to reach that trigger level, whether it is pressure trigger or flow trigger. It doesn't make any difference.
Lovely, thank you for answering that question. There's been a question from the Facebook Live as well. What about decreasing the trigger threshold?
Yeah, so that is going to solve the problem too. If you decrease the trigger threshold, that means that you're not allowing the patient to trigger again, but you may not trigger the first one too. So if you decrease or let's say if we set it at a higher level, so let's give an example. If the trigger is at 5 liters per minute of the flow, and you increase that to 7 liters per minute, you may actually eliminate triggering altogether. So that's the difference. So it is actually not ideal. Yes, we can increase the flow if it is flow triggered, or decrease the pressure if it is pressure triggered, and see if you eliminated the double triggering, great. The patient, if he's able to reach the trigger level, even with that higher threshold level, that means that you're not able to solve it. If you eliminate it, you may eliminate both the initial one and the second one. So you need to just stand at the bedside of the patient, play with the trigger level, and see if that's going to eliminate your double triggering. But this is very good question, actually. Both questions were great. Indicates that you're understanding the concept of double triggering. And this happens a lot, by the way. You go tomorrow at the bedside and you will see that lots of patients have double triggering. And in fact, if the inspiration is very prolonged, you may have triple triggering too. So you can triple trigger the ventilator. You can imagine if the patient is on volume control mode of ventilation, what happens to the volume. However, your limits will actually, if you have limits, it will restrict the consequences of double or triple triggering. Let's just give an example. If your pressure is limited at 40 centimeters of water, for example, okay, the first breath resulted into 25 centimeters of pressure, okay, and the second one requires another 20 centimeters. The pressure would go up to 45. But if you have a limit at 40, you won't have that much tidal volume in. So that's why it is very important to set those limits to protect the lungs, not only from not only based on the protective lung strategy, but also for the unwanted consequences of dyssynchrony with the ventilator. So by setting the alarm limit at, ideally, I would set it at 35. If you set it at 35, and if you have double triggering, you won't get that much tidal volume inside the chest with the second one. And another good question would be asked if which one is better for double triggering, pressure control or volume control? Anybody would be able to answer that question in protective lung strategy or in ARDS patients? If you have double triggering, would you rather be on pressure control or volume control? Would anybody be able to answer that question?
Pressure control.
And the reason being?
To minimize tidal volume to be doubling.
Excellent. So at least it's going to be larger tidal volume than the initial one, but it would not be double the target tidal volume. You're right. The pressure is going to be the same, so you're not actually breaching the pressure limit in protective lung strategy. The volume will be added, more volume will be added, so you may actually breach the limit for the tidal volume. But compared to volume control, the pressure is doubled and the volume is doubled. So yes, pressure control is a better mode for double triggering, but you don't want to see double triggering in patients with ARDS altogether. You need to make sure that you manipulate the inspiratory time. This is how you're going to start. You start with the inspiratory time. You may play with the trigger, see if you eliminate the second breath. But if you fail to eliminate it based on the inspiratory time and the trigger at that time, the only solution would be to sedate the patient a better way. And the last thing you do is you paralyze the patient.
Thank you. There's 2 more questions in the chat at the minute. So Yasser has asked, what is the maximum inspiratory time that we're allowed to set?
Well, it's there's no such a thing called maximum inspiratory time. You need to have an inspiratory time that eliminates this problem. At the same time, you have enough for expiration. So always when you change the inspiratory time, you need to look at the expiratory time. Of course, the rate is fixed. So by changing the inspiration, prolonging the inspiration, your IE ratio is going to change. You have more inspiration. So since the respiratory cycle is fixed, you're going to have less expiration. Like in this patient here, if you see the one on the screen, you can see that probably you can, I don't see a normal one actually. I need to see not the other one too. So both are not good examples, but the expiratory time is what your target. You need to make sure that the patient exhales all the way to 0. As long as you have a 0 flow at end of expiration, you can take this time and put it on inspiration, so you can prolong inspiration longer based on that. So there's no limit for it, but you have to make sure that the patient has enough expiratory time to exhale everything in the chest.
Thank you. The next question in the chat is from Iyad. Would increasing the flow or inspiration time solve double triggering?
So the inspiratory time, if you increase it on the ventilator, yes, it may solve the double triggering. However, the flow, if you increase the flow, you just deliver the breath faster. So in volume control mode of ventilation, if you have a tidal volume of 500 and the flow of 30 liters, inspiratory time of 1.5 seconds, you end up using 1 second to deliver that 500 in. And you have 0.5 seconds for the plateau. Now increase the flow, double the flow from 30 liters per minute to 60 liters per minute. You can deliver the 500 faster in 0.5 seconds. And then you have 1 second for plateau. Inspiratory time does not change. And you don't solve the double triggering. So it's only the inspiratory time that needs to be prolonged in order to solve the double triggering.
Lovely, thank you. There's no more questions in the chat and no more questions on Facebook. Does anyone else have anything they would like to ask before the Zoom call ends? So we have a question in the chat then from Paolo. So how do we distinguish double triggering from reverse triggering without an esophageal probe?
It's going to be very difficult. Let me see if I have a slide about that. And let me just explain. Reverse triggering is contraction of when you deliver the breath. Okay. So let's see the first one, whether it's triggered by the ventilator or triggered by the patient. Okay. The patient stops his inspiratory effort. However, because of the inspiratory volume, you're stretching or you're pushing on the diaphragm contracted again. And that caused another breath. Okay. So it is difficult to determine if you don't have esophageal pressure, because you're looking whether this second breath is started by the patient or by the pushing on the diaphragm. You need to see the positive pressure in the chest. Without the esophageal pressure, I don't think we're going to be able to do it. I have a slide about that. Let me just see if I can see it. I'm not sure if I can. Let's just see. Yeah, it's actually, you know, the thing is, in reverse triggering, you may see some exhalation. Like the example that I have here is actually you can see some exhalation here. However, if this is happening earlier here, you don't see any exhalation. And this is the inspiratory pressure for the first breath. Okay, this is the esophageal pressure, or I mean the diaphragmatic potential. You can see here how it is contracted again. The orange one is actually contraction of the diaphragm. So the second one is triggered by the contraction of that diaphragm caused by the first one. So I'm not sure if Badro is actually asking this question, if you have any other answer. I don't think you're going to be able to differentiate between the two without esophageal pressure, because they're going to be similar. And that's good, very good question. Thank you.
Thank you for your question. There's no other questions in the chat or on the Facebook. Any final questions before the evening's over? Or morning?
It was Paulo who asked that question actually. So Paulo, do you have anything to add to what I said?
No, professors, thank you very much. Very clear as always. Thank you very much.
Thank you. Okay.
Okay, so I think that's the end of this evening's session. Thank you very much for everyone who joined, and also for people who contributed with the questions at the end. The questions are really helpful because they help other people understand the topic more thoroughly as well. So thank you as well for answering those, Dr. Carola. Just a reminder again then that there's options online to become a member. So to become a silver member is $29 for the full year, and that gets you access to lots of different things, including PDFs, the presentation, and previous presentations and the recordings. Just a note about the next session. We don't have a ventilator session next week. We have a sepsis update instead, and that will be on the 18th of August at 9 p.m. RIA time. So thank you very much for joining tonight. And thank you, Dr. Carola.